A very good morning, ladies and gentlemen, and a very warm welcome to all of you. I'm your virtual host, Diksha Rena, and it's my pleasure and privilege to welcome you all to this eventful morning at Day 2 TOS Vision 2021, the sixth annual virtual conference of Telangana Ophthalmological Society at Dr. S. Badrinath Hall. Ladies and gentlemen, moving on to the first session for Day 2 on State of the Art Cornea, I would like to take the honor to invite our esteemed chairpersons. I welcome Dr. Rajesh Fogla, Chairperson, Co-Chairperson Dr. Nikhil Gokhale, and Moderator Dr. Nitesh Narai. I would now like to hand over to our moderator, Dr. Nitish. Dr. Nitish, please proceed. Over to you.
Very good morning to all of you. Without wasting much time, we would like to invite Dr. Donald Tan, who we all agree would need no introduction at all. He's a founding member of Singapore Institute and Asia Cornea Society. If I go on with his introduction, I would say it would go on the entire duration of the instruction course. So he has made a definite so much of contribution in the field of ophthalmology. Donald Tan, without Professor Donald Tan, without wasting much of our time or your time, we would like you to go ahead with your keynote lecture, the current perspectives in the management of corneal edema.
Thank you very much, Nitish. I'd like to thank the organizing chairman, Rajesh, and Nitil and Nitesh for inviting me. I'm going to share my screen. Okay, so when Rajesh invited me, he texted me and he said, I'll let you know. And I had this topic, which he gave to me, current perspectives in the management of corneal edema. You can hear me okay?
Yeah.
Okay, so I thought quite a bit about what I can speak on in 20 minutes. So I've decided to talk on 4 perspectives as I see it for us today in the management of edema. And let me see whether I can get this going. So 4 Asian perspectives, okay? We are in Asia, so that's what I'm focusing on. First perspective, what are the results of our transplants like in Asian eyes? Which should we do? For corneal edema, for endothelial dysfunction, should we be trying to do a PK or a DMAC or a DSEC? Maybe DSEC's as good as DMAC. Why do you need to do a DMAC? Secondly, it's all about perspective in terms of what sort of disease we have. Our indications in Asia compared to the West are very different, so we don't necessarily need to follow what's happening in the West. A third area, of course, is I'm going to focus on DMAC, the surgical technique for the Asian eye, and this is what I've been doing for some time. It's just my perspective. And then finally, I'm going to talk about a change of environment, always welcome in this Delta COVID era where we're all locked down. Okay, and I'll come to that right at the end. So let's start off with graft survival. We just published this very recently this year, looking at our 20-year review of Asian eyes for PKs. It's the Singapore Corneal Transplant Registry, and you'll basically see that it drops quite dramatically. By 10 years, we are talking about 55-year survival. By 20 years, 44%. All right, so we do know this, and we know that it is the endothelial damage, either endothelial rejection or late endothelial failure, which accounts for more than 60% of graft failures. So this is the challenge for corneal edema. We then look at the 3 operations, PK versus DSEC versus DMAC. We looked at 2 diseases, Fuchs endothelial corneal dystrophy and bullous keratopathy, 5-year survival rates. We just published this about 2 years ago. And you will see a differentiation. For PK, 5-year survival is 54%, DSEC is 78%, and DMAC wins 97%. So DMAC is better. What about the types of edema that we are facing? The Asian indications. On the left is a Fuchs endothelial dystrophy, quite early stage, and mild edema, and that's the commonest that the Western Hemisphere sees and operates on. What we are more likely to have is PBK, as you see on the right. So there is a world of difference between East and West here. Okay, you can see your comorbidities are higher. Not only that, but in terms of disease presentation as well. On the left, early stage disease. On the right, what we tend to see, much later stage disease. So what we're seeing on the right is definitely more challenging. This survey, global survey, came out a few years back now. But basically, if you look in Asia, in that purple, which is where we are around, is infection. So that could be either PK or DALC. But in this pink, or the salmon color, is bullous keratopathy. On the yellow here, looking at the northern US, North America, yellow is Fuchs. So the leading indication in almost 30 countries, secondary bullous K, 30%. Okay, but it's further down on the list in terms of actual transplants because there are more Fuchs surgery being done in the West, both in Europe as well as in the US. But basically, secondary bullous K is our type of corneal edema. And when you split the two and look at graft survival, there is a difference. Okay, so if you look at Fuchs endothelial dystrophy, really, whether it's DSEC or DMEC, there is no difference. High survival rates at 5 years, 96, 98%. But if you look at bullous K, you see that DSEC does not as well as DMEC, 65% versus 94%. So we should do DMEC as far as possible for bullous K, which is our type of Asian disease. Let's look at surgical technique for DMEC now, for the Asian eye. On the left, it's a nice case to do. This is Mark Terry showing a really nice, simple, straightforward blue iris DMEC. Similarly, in the middle is Rajesh. He did this as live surgery a few years ago in Seoul at the ACS scientific meeting. A little bit more challenging now. AC is shallower, higher vitreous pressure, and also the color, a bit harder to see which way is up, right? But what you see on the right is what you don't want to do for live surgery. These are the patients we do see. Visualization is not only poor, but there's a lot of peripheral anterior synechia, a fixed dilated pupil, abnormal chamber, sometimes the posterior capsule is open, unstable IOL, etc. So all of these are the relative contraindications for DMEC, which unfortunately, this is what we do see quite often in Asia. So for some time now, I've been trying to democratize DMEC. How do we make eyes more DMECable, or at least make DMEC more easier to perform or more predictable? And for a long time now, we've been using the pull-through technique. This was developed from long ago with DSEC, with the Sheets glide, the Busin glide, and the Endo glide. So now you're holding onto the tissue, so you enhance surgical control. You also control the chamber depth with a low-flow AC maintainer, and we used an Endo glide, which has got a closed system. So that was the surgical device. And we used our own DMEC version of the DSEC now, of the inserter. And then the advantage also with this approach is that we are coiling the tissue endothelium in, so it automatically unfolds, which makes it easier to have the graft unfold. And we've been doing this for some time. We published the new inserter, the DMEC inserter, which is about a couple of years old now. We published this in May last year, I think 96 cases. And you can see we trifold the tissue, a bit narrow at one end, and we load it into the EndoGlide DMEC cartridge, which looks like the original DSEC cartridge, but a lot narrower. This goes through a 2.7 millimeter clear cornea incision, whereas the old DSEC inserter went through a 4.5. Okay, so it looks very similar to our DSEC EndoGlide technique. And you can see then it pokes out a little bit and we go through a clear cornea incision. I still will suture this, but at least it's a smaller wound, so it's a better chamber control. The AC maintainer is opposite the device, so next door to the EndoGlide forceps. So as we pull it in, I'm bringing the graft to the AC maintainer, which is on a very low flow. And so what happens is that once you remove the cartridge, the chamber gradually shallows, and by itself, this graft will start to open. And what I'm doing there is I'm just closing the wound a bit. It deepens the chamber and it opens. So we did this in 69 cases. We had a 1.5% failure rate, cell count about 33%. But we demonstrated this as being possible. And in fact, Half of them were in PPKs and about 20% in failed grafts. So this worked really quite well. You can see how the tissue just gradually opens up on its own with a bit of what I call unintelligent tapping. So not as intelligent as Rajesh there. This patient did very well and 27% cell loss. Lastly, a change of environment, always welcome, I think. The issue are these cases, and I refer back to them. These are the most challenging cases. Fortunately, not all our eyes come like this, but they may do. So these are very challenging cases. And basically, we're talking about a hostile environment for the graft. So even if you get the graft in there, it's got to stay in there and it's got to live in there without losing endothelium. Okay, basically, we're talking about all forms of corneal decompensation with marked anterior segment disorganization. So the hallmarks, the anterior chambers are not normal. They're limited by peripheral anterior synechia, iris adhesions. Sometimes an IOL is there, like an ACIOL. Sometimes there are tubes, 1 or 2 tubes in the anterior chamber. Not only that, it's your posterior surface. Don't forget, when we're tapping and doing DMEC in the conventional way, we're tapping on what needs to be an intact iris, which needs to be constricted rather than on an IOL surface. And a lot of these eyes are aniridic, or they're partially aniridic, or they're fixed and dilated. Sometimes it's an open vitreous cavity, sometimes it's frank aphakia as well. So you can't tap these eyes very easily at all. Some of them have previous failures, like a PK or a failed DSEC or a DALC. But the problem is that, and I've been doing these cases for a long time, and we were able to do these cases with the pull-through DMEC endoglide technique I've just shown you. Even if you're successful, it's a bit disappointing because weeks to months later, a lot of these eyes, the PAS recurs, iris gets stuck to your DMEC graft, and then you lose cells, you get rejection or DMEC graft failure. That is the problem. So here's a patient, 61-year-old male, glaucoma, and he had a complicated cataract surgery. He had a mitomycin C trap. There was an IOL exchange and a Barveld tube, and the cornea failed. The surgeon did a PK. Unfortunately, there's 360 degrees of PAS. And what happened was the graft failed, hand motion vision. You can see it's stuck all the way around here. So back in 2017, I did the DMEC procedure. I separated the PS beautifully, kept the iris nicely in place. You can see the chambers deep now. We did the syneculisis, and he got 612. So I did a nice DMEC underneath the PK. Then the angle started to zip up again. And after a few months, I noticed this coming back. Don't forget, he had 1 tube there. Pressure went up a year later. Micropulse TCP was done, did not work, and basically required a second valve. This time was an Ahmed valve. And then the PS increased even more to 270 degrees. And of course, ended up with graft failure, count fingers vision again. So just within a short period of time, we left back with this problem again. So 2 years, that's all it lasted. And I think it's the recurrence of the PS, which is the problem. So I've shown you these 3 key points before on how we make DMEC more predictable to perform. Today, I'll show you the 4th key change, and that's to change the hostile environment or the anterior chamber. What you see here is the artificial iris. We've removed the abnormal iris, the PAS, all the scar tissue, deepened the chamber again, and then replaced the previous iris with an artificial iris. So this is the concept of reconstructing the anterior chamber before you do DMEC. So if you restore the chamber angle, there's more space, you remove the PAS, you release a lot of adherent non-functional iris and scar tissue, which brings blood vessels, etc. And then you replace the iris diaphragm with an artificial iris. I've been using the Human Optics Custom Flex artificial iris for some time now, a couple of years. It is made in Germany, it's made of silicon, and it is fully FDA approved. There are 2 versions. I tend to use the one which is suturable, and because a lot of these cases you need support. And you're basically trying to convert this image on top to the bottom one before you do the DMEC. Okay. So here's that patient. So this is a patient who had a complex PBK. You can see here, fixed and dilated pupil, PAS. He had a dropped nucleus during cataract surgery, IOL drop, pars plana vitrectomy, sclerofix, cornea decompensated. And what I've done here is I've done the 4 peristomies, and I marked with T's the suture sites of the iris sutures. And this is about 1.5 or just behind the limbus. And these are partial thickness scleral wounds. This is a standard MVR blade. This allows me to put my endoglide forceps in to grab the sutures. And there are 2 on each side, so they're mattress sutures, and there are 4, 1 in each quadrant. So it does take some time, 4 sutures. And here I'm using the Asico Dauk marginal dissector to break the PS. Once you break the PS, I just use a vitrectomy to excise the iris. And here is the artificial iris, which we trephined and sutured in place with 4 of the sutures that we are using. And we're inserting it through about a 4.5 millimeter scleral wound. At this point, you have to be careful not to dislocate the IOL, which is scleral fixed. Here, because we're going to do a DMAC later on, you don't have to worry about being too forward against the endothelium, since you're going to replace it anyway. These sutures are exteriorized with the endoglide forceps, 2 on each side, and then we tie it off. And these are Gore-Tex sutures. It's actually a 7/0 suture. It's a Gore-Tex sutures for IOL fixation. And then we rotate the knots and close the conch. And that's what it looks like after surgery. And you can see here in the immediate post-op, of course, the cornea is still swollen, but you can see that the iris is in place now. There's a bit of hemorrhage and fibrin from all the manipulation. We let that all settle. And then about a month later, this looks a completely different eye. This is the same eye with the artificial iris, and now the DMAC is, frankly, DMACable. It's quite easy. You'll notice that the iris does not collapse, so you don't get a flat chamber. So that's good. You have to be careful not to make it too deep, otherwise you end up with a deep chamber. But this is the standard, and now we're using the standard DMAC endoglide. Goes through the same wound as normal. And you can see now it's a doddle, so it's easy, frankly. Everything's quiet, the artificial iris stays there, you don't lose the chamber. And then it's not a difficult procedure. So of course, this is one of our first few cases, a sort of easier case in a way where we could see what we're doing. Okay, so what we've done is we've made the DMAC uneventful now. And that's all because a month ago, we basically changed the environment to make the eye more DMACable. This patient did very well, amazingly 6.7.5 at 2 weeks. 1 year follow-up, I did a zoom for this patient, 6.6 vision, and the cell count 1800. This is her other eye, so pretty good. This is a standard iris brown color. You can get a customized one if you want, but we can't be bothered. The brown is fine. Here's that difficult case I told you, right, which had a PK, and then I did a DMAC, and then you had a PS, and it failed. So we did the same procedure, and after the stage 1, you can see the chamber is full now. The pupil is standard. This is a 3.8 millimeter pupil, the artificial iris. This is eye is now DMAC ready, and here's the DMAC. So again, even though here the visualization is much poorer, and we have a PK underneath to match the graph, so it's a bit more difficult. There's a slightly higher risk of donor dislocation, and of course, this eye has 2 tubes now, so not a simple case. But, pretty uneventful. I'm just trying to get the graft in place exactly in the center of the PK now. Okay, and we're getting there. This patient did very well. Central cornea thickness 460, 612, 10 months follow-up at 612. So doing pretty well. Okay, so we've done 11 cases, varying from 6-year-old child to 88 years old. Most of them will have fixed dilated pupils, aniridia, broad iridectomies, etc., etc. 9 out of 11 had pre-existing glaucoma. So these are hot eyes. 7 out of 9 had tubes or traps. 7 out of 11 had 17 failed grafts. So on average, 2.4 grafts per eye. These are what they look like after the first stage and what they look like after the DMEC. Overall, we've got 20 months follow-up ranging from 7 to 24 months. All 11, the iris surgery has been fine. 9 had DMEC, but 2, and you can see here, but 2 of them delayed due to COVID. In the end, we had to do PKs. So these were the 2, one of the 6-year-old child, and the PKs are both clear at the moment too. We've had some complications. I dislocated IO haptic, 1 potential failure because the eye went to hypotony, and 1 retinal detachment. But that's not bad odds considering these eyes. So my current perspectives in the management of corneal edema. I think unlike the West, our Asian form of corneal edema is pseudophakic or secondary bullous keratopathy with the comorbidities, and our cases tend to present at a later stage. That's more challenging. PPK has got a poorer graft survival rate compared to Fuchs, again, probably due to comorbidities. Again, we have more challenging disease. DMEC, actually, if we can do it, has got the best survival rate, even for PPK, more than DSEC. But again, it can be very difficult to perform. So on the upside, the pull-through endo-in DMEC approach using the DMEC endoglide provides for better surgical control and also works well for the Asian eye. And now we can reconstruct the AC using the artificial iris. And I think this is a new approach for some of these more complex cases to make DMEC a little bit easier for all of us. Thank you very much for your attention.
Wonderful talk, Donald. Just for the benefit of the audience, what would be the approximate cost of the artificial iris from Human Optics?
You know, I can't remember. I think it's about $2,000 US dollars. I think so. Don't quote me on this.
And but in Singapore, this is reimbursed by the insurance, right? Or patient?
No, not necessarily. No, depends.
Depends.
No, not necessarily. Yeah. Yeah.
What
but I tell you, I know the people, once I presented this and we published it, they contacted me and they said, you know, if there's anything you can do, etc. So who knows? I mean, if you ask them, and they're quite excited that we're using this for DMEC. And my guess is somebody wants to start, there's no harm asking them, could you provide one?
There is a Russian company that also manufactures similar artificial iris, and I think it's a little cheaper than the one from Human Optics, but they don't give you the customization, like you can't match with the colors like what Human Optics can do.
Yeah, I think you have to be very careful because you can confuse this with cosmetic artificial iris, which is very bad. And there are a few out there which are not well tested. And that's the problem. They all cause UGH syndrome and hyphema and all that. So to be frank, this is the only one which is approved by US FDA. It's been approved for about 3 or 4 years now. And I dare not use the rest.
If you see a patient with this peripheral synechia where you intend putting in the artificial iris, would you do that as the primary option, or you would still go ahead and attempt one surgery where you do synechia lysis and try to do the initial EK, and if that fails, you move on to doing this 2-stage surgery?
Yeah, so I'm generally quite conservative. If I find there's some PAS, you know, 1 quadrant or so, or maybe 4 clock hours, and it's not major high risk, it's not, you know, I would just do the synechia lysis. Before this, and in fact, it was taught to me by John Dart, right? And he did this in Moorfields for many years. He would just remove the whole iris, okay, and live with the glare. And I used to do that. But nowadays, yeah, you're right. I think the first time you do this, I would just do a PAS synechia lysis. You can do a pupilloplasty if you can to tighten the iris to prevent the PAS. And if it fails again, then you have to repeat it. Then I would do this with a DMEC. The good thing is DMEC is, you know, I think if the rejection rate's quite low, you can do a repeat DMEC. It's not so bad. It's not like repeating a PK.
And what would be the typical duration between the first surgery, like you put in an iris implant and then you go back and do a DMEC on an average?
I think there are 2 things you want to look for. Resolution of inflammation, which is the fibrin and the hemorrhage, because you've eaten up iris, right? You victim. And secondly, the stability of the iris. I don't think the stability iris is an issue at all. We've not seen any issues. So I just wait for the fibrin to settle down. And my guess, it could be earliest is 2 weeks. I've done it at 3 weeks. I've done it at 6 weeks, but about a month or so. There's no hurry.
Dr. Donald, how many of these patients would require glaucoma surgery post-op?
I have one patient who has required a tube, and he's getting worse, etc. There was a question before, are we causing more glaucoma or iritis? No, we're not seeing that. These are all, by the time, you've seen the cases. I don't do these in simple cases. So almost all of them have got glaucoma already. I don't think the risk is any higher as doing a repeat DMEC, because after you do that, you use steroids, the pressure goes up anyway. I don't think the artificial iris contributes to more glaucoma challenges in IOP measurement.
So anatomically, basically, they would be placed around the base of the iris.
That's right. Yeah. So you have to decide where you want to place it. It makes sense if there's PAS to place it anterior to the PAS, but not too anterior, obviously.
But you end up removing the entire iris and then you place these artificial iris.
That's right. Yeah. I mean, the whole point is you want to prevent PAS from recurring again. I did have one patient where I separated everything, and he was a young man. And so I left the iris there and I put it on top. Then I see the AC shallowing after that. So that was a problem. So I think we are always afraid of removing iris. I don't think we should be. With a vitrectomy today, you get minimal bleeding. And I think I regretted not removing the iris more than having to remove the iris.
Thank you. Thanks a lot, Dr. Tan. I think with
one question.
Okay, Dr. Rishi.
Hi.
Dr. Tan,
Hey, Rishi.
lovely talk and beautiful videos are always so much to learn from you. I just wanted to ask you, in a patient with a tube or a trabeculectomy, sometimes there's a large area of conjunctiva that's not available. So if you have to use this cortex suture and fixate it, you obviously need to fixate it in all quadrants. What do you do in the site which has a filtering procedure?
Yeah, so I mean, like some of these cases, I had 2 tubes and 1 trab, right? So you don't want to disturb. Yeah, so I think you just need to plan very carefully. So before the surgery, I've actually mapped everything out, because sometimes you've got your IOL sclerofixation points, you've got your so there is not a lot of real estate in the conch. So before that, I examined very carefully scarred conch areas. Those areas I cannot touch where they're blebs or tubes, right? And then you have to plan the 4 sutures accordingly. It's all in the planning. So by the time you see this, I've all measured it out already. So that's what you need to do.
Sure.
I think we can go on with the next talk. Dr. Nikhil, are you there? Yeah, Dr. Nikhil has started sharing his screen. Dr. Nikhil is a senior ophthalmologist. Again, Dr. Nikhil doesn't need any introduction. So he'll give his talk on keratitis management. Dr. Nikhil.
I'd like to thank Dr. Rajesh and the Telangana Society for giving me this opportunity today. You can see my slides. You're able to see and hear me?
No, you need to.
We can see you, Dr. Nikhil, but we can't see your slides yet.
You need to share your screen.
Screen share.
Okay, one second.
Come initially and then it disappeared. Yeah, I think, yes, now we can see.
Yeah.
Okay. Yeah,
Yes.
thank you. So what I thought today is that I would probably discuss some of the evidence-based management of fungal keratitis. For also talk maybe 1 or 2 slides on when do we suspect infection with pythium. Look at how we should manage bacterial keratitis in our own practice. And maybe again 1 or 2 slides on microsporidial stromal keratitis, basically because these are often missed or misdiagnosed entities. So when voriconazole came into the picture, I think most ophthalmologists wanted to switch to voriconazole from natamycin. And this trend, however, came to a stop following the mycotic ulcer treatment trial, which was a landmark study by Arvind Eye Institute, which told us that natamycin is better than voriconazole for fungal ulcers. However, for non-fusarium ulcers, they were equivalent. However, in fusarium ulcers, we know that natamycin is superior to voriconazole. Before we know this, also, we need to know what are the isolates that we see in our own settings. In South India, fusarium is the most common filamentous fungus, which is causing corneal infections or fungal ulcers, whereas in the north, east, and the west, the aspergillus is a much more common fungal isolate which is found. With voriconazole, we also started using intrastromal injections and intracameral injections. So Dr. Namrata Sharma published this article on the role of intrastromal voriconazole as compared to topical therapy. And in their study, they found that topical voriconazole is beneficial for recalcitrant keratitis. However, when you give intracameral injections, or intrastromal voriconazole, it did not add any beneficial effect over the topical therapy itself. When we look at oral antifungals, there are several options that are available, and these drugs will vary in the spectrum, the MIC level, the side effects, and the cost. The MUD2 trials were basically trying to compare oral voriconazole versus oral placebo in patients who had corneal ulcers who were also receiving antifungal therapy. They found that there was no difference in the rate of corneal perforation, the need for therapeutic keratoplasty, the visual acuity, or the time to epithelialization. So in essence, they mentioned that oral voriconazole does not seem to help treatment of filamentous fungal ulcers. A subgroup study from the mycotic treatment trial 2 again showed that, however, in fusarium infections, oral voriconazole did reduce the number of patients going in for a therapeutic graft, and they mentioned that fusarium keratitis may benefit from from adding oral voriconazole to topical natamycin. Again, at All India Institute, they tried to compare ketoconazole, which is used very often by most cornea surgeons and ophthalmologists, with voriconazole orally for severe ulcers which were large in size and involving more than 50% depth. They found that both the drugs do achieve more than the MIC levels in the tear film and in the serum, and the levels of the drug was higher with voriconazole than with ketoconazole. And the MIC levels in general were higher for fusarium as compared to aspergillus. Comparing the two drugs, they found that voriconazole had better outcomes with lower number of side effects. However, if you see the cost factor, I think for our country, it's a phenomenal difference in the cost of the two drugs, which might make a difference when we prescribe it to some of our patients. The TST protocol was again published by Dr. Namrata Sharma et al. So basically, just a little modification of that here. So when you have a patient with filamentous fungal keratitis, topical natamycin continues to be the drug of first choice for large ulcers or deep ulcers, or patients who are diabetic, immunosuppressed, where there is limbal or scleral involvement, or there is suspected posterior segment involvement. You would give an oral azole along with the topical treatment. If the patient does not seem to be doing well, you can add a second drug, and this would be voriconazole eye drops. If the patient is still not doing well, you could consider giving intrastromal, intracameral antifungals. You could do an anterior chamber wash. And if the patient is still not improving, you could repeat these injections every 72 hours. And subsequently, if the patient is still getting worse, you might have to do a therapeutic graft. During the course of this treatment, at any point of time, if you have a corneal melt or a corneal perforation or thinning, you might have to straight convert to a therapeutic keratoplasty. I think what's very important today is that when you have patients who are not responding to any form of medical treatment that we conventionally give, this is where we should be watchful, and we should try to see whether we are treating a fungal keratitis or it's a pythium infection. This is because pythium is basically an oomycete which looks like a fungus. However, it differs from fungus because it does not have ergosterol and chitin in the cell membrane and the cell wall. And how this makes a difference is because the antifungals that we conventionally use, the polines and the azoles, basically target the ergosterol. And if ergosterol is not there, these drugs are ineffective. So what finally happens is that none of the antifungals that we conventionally use seem to work when you have a pythium infection. Caspofungin, which works on the beta cell, beta glucans, may have some effect on pythium infections. So this was a young patient who was a contact lens user who came to me, and I tried 6 weeks of all various types of antifungal therapies that could possibly be done. And then finally, we realized that this was a pythium infection. This is about a few years back. And retrospectively, when we looked at the smear report, it did say that these were sparsely septate filaments. However, the culture had not identified the fungus. We need to look carefully for findings such as the reticular dot-like infiltrates and the tentacle-like extensions. So if you come across a non-responding fungal ulcer, we need to relook at the smears. If you look at the smears carefully and you find aseptate filaments or very sparsely septate filaments, if you see broad hyphae with ribbon-like folding, there is a possibility that this may be a pythium infection. And with a high index of suspicion, especially if they're not responding to antifungal therapy, I think one could send the material to a higher institutional setup or a laboratory where they can do specialized staining. They can look for zoospore formation and DNA sequencing to confirm what you're treating. This is because the treatment of pythium today is based on a triple drug therapy, which is basically using topical and oral linezolid and azithromycin. And this treatment, as shown by LV Prasad, has really improved the outcome of patients with this type of corneal infection. And in patients where the medical treatment does not seem to work, early surgery is something that should be done as early as possible to debulk the infection and get rid of the organism. Now share with you a few slides on how we should look and treat bacterial infections in our clinic. And for that, we need to answer a few questions such as what are the common organisms that we are looking at? What are their susceptibility patterns? How severe is the infection? Are we expecting any resistant organisms? And how do we treat our patients? Do we have reliable microbiology facilities in our setup? What are the various drugs available and the prescription trends? So we are well aware that more than half of our infections may be bacterial and gram-positive infections, especially the staphylococcus and the pneumococcus are the ones which we are predominantly looking at when we treat bacterial corneal ulcers. When we talk of gram-negative bacteria, though a small subset, maybe about 10% of our infections are gram-negative, Pseudomonas is probably the most common in about half of our cases. The Essex study has also shown from India that Pseudomonas and Strep pneumoniae are one of the most common organisms that we encounter. A study from Arvind Eye Institute mentioned that when you look at fluoroquinolone resistance from over a period of 10 years, there is basically a poor activity against Staphylococcus species. And they mentioned that in their conclusions that the fluoroquinolones may not be the ideal therapy for staphylococcal corneal ulcers. So what this means is that half of our bacterial ulcers, which may be staphylococcal in origin, one should wonder whether we should use a fluoroquinolone or use some alternative medical therapy. With regards to Pseudomonas, more than 30% of our isolates are drug resistant and about 25% of them are resistant to multiple classes of antibiotics, as has been shown by the ASIC study. And as you can see here, more than 20 to 25% of the drugs are resistant. Similarly, studies from India have shown poor efficacy of quinolones in patients with infection. So basically, we need to look whether we are looking at a community acquired or a hospital acquired or an infection acquired in a sick eye where you expect drug resistance. And in these situations, probably it may be better to use a higher generation of an antibiotic. We also need to look whether we treat based only on clinical judgment or on smears, or we have a whole gamut of smears, cultures, facility available at our clinic. And if we are to use, we need to see whether we want to use a monotherapy or a fortified therapy. Cornea surgeons, more than 60% would use fluoroquinolones as a first-line drug alone or in combination when treating corneal ulcers. No commercial interest, but I think levofloxacin is the one of the fluoroquinolone which is the highest concentration which is available today, and maybe more effective in as a first line single monotherapy if you want to try and use. Of course, we would have to use higher antibiotics when we come across drug-resistant organisms. And this is a sort of an algorithm which you could try and inculcate in your own practice. However, the protocol has not been validated, and it's up to the cornea surgeon to see whether he is comfortable using this. So basically, for a small ulcer, one would use fluoroquinolone, which is not fulminant. However, for large fulminant ulcers, it's imperative that you do a smear. At least testing is done, and if the smears are negative, you can use fortified drops. And if the smears are positive, you correlate them with your clinical judgment, look at the risk for resistance. And in patients with a high risk of resistance, probably it may be wise to use a higher generation antibiotic from day one of the treatment. Of course, when culture results are available, you can modify treatment based on whether the patient is getting clinically better or worse. So these are just some examples of how you would like to treat a patient. So if you have a community acquired infection where the risk of resistance is low, you can use conventional antibiotics. But when you have a hospital acquired infection or an infection in the eye where there's a high risk of resistant organisms, you could use higher generation antibiotics in these patients. And just to say that we come across these type of pictures where you have fluffy infiltrates which are constantly treated with steroids and antivirals, and they continue to not improve, and they get worse when they stop steroids, invariably requiring a therapeutic graft, sometimes requiring a biopsy to confirm the clinical diagnosis. So I would just like to mention that if you have a viral stromal keratitis picture not improving with antivirals and steroid, consider the diagnosis of microsporidia. The awareness levels are pretty low at this stage, but because there is no medical treatment, I think it's important that we diagnose them correctly and probably go ahead and do a corneal graft. Thank you.
Thank you, Dr. Nikhil, for an excellent talk. So since we are running short of time, shall we go ahead for the next talk? And can we have questions towards the end of the session? Dr. Rishi, are you ready for your next talk? Yeah, Dr. Rishi.
I'm ready.
Yeah. Thank you.
It's not allowing me to share. Somebody will have to unshare.
Dr. Nikhil, you'll have to unshare the screen.
Sharing anymore, actually.
Okay. Yeah, we can see your screen, Dr. Rishi.
At the outset, I'd like to thank Dr. Rajesh Fogla and the TOS for giving me this opportunity. Mine is a simple talk, not complicated like the previous ones. I hope everybody can relate to it. So I've just kept some basic videos of how to do a pterygium surgery in such a way that you'll have good outcomes, both cosmetic and lower chances of recurrence. And then we'll just see some complicated scenario also. So when does one really need to operate a pterygium? Traditional teaching, especially when we were all doing post-graduation, was don't touch a pterygium till you really need to operate it. Because at that time, or maybe a little earlier, people were doing a lot of bare sclera kind of surgeries where recurrence rates were very high. So one would only want to touch a pterygium when you needed to. So the traditional indications were if you were having a progressive pterygium, or if it's coming to the visual axis, or it's causing a lot of visual effect, diplopia, restriction of the extraocular muscles, or if the patient is very symptomatic. But I think as our outcomes have improved because of newer techniques, we have become a little more liberal and our threshold has lowered. So we are doing a lot more cosmetic procedures now if the patient doesn't like the way it looks in the eye, etc. And if they want to use contact lenses and the pterygium is preventing them from using it. It's important that when we see a pterygium initially, we document the pterygium, maybe by corneal drawings or taking serial slit lamp photographs. And we basically document that it's progressing. Okay, and that makes it very easy for us to understand that it's a progressive pterygium, and also to explain to the patient. It's very useful when especially in our country, patients are always doubting that you're just advising them surgery to make money, and they may go to somebody else and they'll say that you don't really need to get it operated, it's very small, etc. So it's useful if you have a slit lamp photography unit to document it, and you can even measure the size from the limbus, how much it's extending. And once you have shown that it's progressive, then your decision making becomes a lot easier. The topography is a very useful tool to really look at the pterygium, and you can see how much the pterygium is causing an effect on the visual or pupillary axis. And if you see that it is distorting the corneal topography in the center, that would probably be a good indication to intervene earlier. Anterior segment OCT is also another useful tool to see, especially in cases that have a little bit of scarring, to see if you need to do some additional procedure as well, to see the depth of involvement. Especially in recurrent pterygiums, it may be useful if the previous surgeon has taken off some stroma as well. That will help you in planning. So the older techniques were base sclera, and people would just excise and close the conjunctiva or transpose it. There was a lot of use of antimitotics, and some people had tried excision with just an amniotic membrane graft. All these techniques had a higher recurrence rate or a higher complication rate. And most of us, at least for primary pterygium, we don't, or simple pterygia, we don't use these. They may be used in concurrence with the main treatment, which is the excision of the pterygium with a conjunctival or a conjunctival limbal autograft. The main steps of this procedure basically are incising the conjunctiva, which means the epithelium, separating the epithelium from the underlying fibrovascular tissue, isolating and dissecting the subconjunctival fibrovascular mass from all the surrounding anatomical structures, excising as far back possible the fibrovascular mass, harvesting of the conjunctival or the conjunctival limbal autograft, and anchoring of the graft to the recipient site and closure of the donor site as well. So the key to having good outcomes without recurrence is a proper excision of this fibrovascular mass, and don't leave any area of the limbus exposed at the end of surgery, so that you have the adjoining conjunctiva or the fibrovascular tissue growing back. So if you cover the limbus well, you'll really usually have a good outcome. Those are the key steps, and the key principles, like I said, is extensive removal of as much as of the conjunctival epithelium as necessary. So don't unnecessarily excise the epithelium. The epithelium is only unhealthy near the head of the pterygium. The rest of the epithelium is actually normal, and a lot of us are doing pterygium, and we remove the entire big pterygium tissue, and then you have such a big conjunctival epithelial defect to contend with, which is totally unnecessary loss of healthy epithelium. So please only incise the epithelium just behind the head. Harvest tenon-free graft as much as possible. The lesser the tenon in your graft, the better the cosmetic outcome, as well as the chance of recurrence is lesser. Like I said, avoid leaving limbus uncovered, and good amount of postoperative therapy. One more point I'd like to add is minimal cautery. Use just as much cautery as is necessary. So I'll just show you some videos. I can't see the timer. Can somebody spotlight the timer?
Yeah, that is okay. That is okay.
So the first step is just incising the epithelium just behind the head, as you can see. I've done that. After you've done that, you hold the pterygium epithelium. I'm sorry, that video didn't play. I don't know why this is not playing, but basically you lift up the epithelium and you reflect the epithelium of the pterygium. So you tent it up and you just cut the fibrillar attachments just beneath the epithelium, so that you reflect the epithelium of the fibrovascular fleshy mass. That's what's being shown here. Now, after you've lifted it off, you also need to expose the wings of the pterygium. So you then go inferiorly and superiorly till you can see the bare sclera on side. You can see that little bare sclera there, and then superiorly I also have exposed it. So you have exposed the upper and lower borders of the pterygium very nicely. Now this is a primary pterygium, so it's very easy, but sometimes in recurrent pterygia, it's very extensive. So sometimes you have to dissect a lot more inferiorly and superiorly, and that's perfectly okay. Sometimes the pterygium looks small, but there's a lot more to it. Then you basically separate the pterygium from this underlying sclera. You can insinuate a scissor underneath and, kind of just, you could lift it off with the head, or you can deal with the head later, as I'm doing in this particular case. So now I have the whole fibrovascular mass in my hand. I can separate it further from the conjunctival epithelium and the underlying tissues. If there is some adhesion with the muscle, sometimes you have to use a muscle hook to pull the muscle, and then medial rectus, and then you can pull the fibrovascular mass away and then separate the attachments under visualization. Don't do any blind cutting. And you can see I'm going all the way. Sometimes you have to go all the way till the caruncle and several cloacas superiorly and inferiorly, as you're seeing here. Then you can deal with the head. It's important to keep your blade vertically so that you don't cut into the stroma. So it's basically like a perpendicular kind of a dissection. And you have to be patient. Somebody can keep irrigating, and all these little attachments will come off with time. Then you harvest your donor conjunctiva. So you go to the superior or the superiotemporal bulbar area, make a little incision, and then insinuate your scissors just beneath the epithelium. So you can see it's a thin graft. I don't really take limbal tissue anymore, and studies have shown that the outcomes are pretty good with just conjunctival autograft. So there's no need to disturb the limbus. So one important thing is when you are harvesting this conjunctival graft, you put it onto the cornea, and when you're cutting the last bit of attachment, make sure the graft is flat, otherwise it will bunch up. And sometimes you have a confusion of which side is epithelial and which side is the stromal side. So put it on the cornea and cut the last piece under visualization, last sliver of attachment. Then you are putting fibrin glue. Nowadays, all my pterygium are under fibrin glue. So I put both on the same surface. Some people put it on the one on the conjunctival graft and one on the donor. I don't think it really makes a difference. So you can put either fibrinogen first or thrombin first. So just you can mark and size it appropriately, but I don't think it matters that much. You can always trim the excess on site. It saves you a lot of time. So this is how I do it. I just spread it out. It's important to remove the excess glue from underneath. So iron the graft nicely. And that's basically the end of surgery. The donor site also can be closed with fibrin glue. I'm not showing that here. It's always good to put a bandage contact lens, these patients. Otherwise, the epithelial defect can make them a little uncomfortable. So I always put that. So fibrin glue versus suture. I know Dr. Fogler uses suturing, and it's a perfectly okay technique. It just takes a little longer. And of course, there are some advantages and disadvantages in both ways, but I think both are perfectly all right. In addition to adhesion, fibrin glue also helps with hemostasis. It's, after all, fibrin glue, it's the clotting mechanism. So that's another advantage. So if you're having a lot of bleeding, putting glue will help arrest that. We have an Indian version which doesn't work as well. So I tend to prefer TCL. So, very gratifying outcomes with these. And sometimes you can't even make out a surgery has been done. These are just a few images. I'm sure all of us have beautiful images. So you can see this by 2 months, you can't even make out there was a tear. You can use amniotic membrane graft. It works like a biological contact lens, but please remember, amniotic membrane graft is not a replacement for the conjunctival autograft. It is only a supplement to close up if you have a lot of conjunctival epithelial defect, especially if it's extensive double pterygium, etc. People have tried using small limbal biopsies or a mini conjunctival limbal autograft, and it basically works like a stem cell transplant, and the epithelial cells grow out from that. And this also works very beautifully, especially in primary pterygia. Double-layered pterygia are always a challenge because, like it was mentioned in the previous talks, real estate for donor conjunctiva becomes very less if you have an extensive pterygium. I have a video, but I won't show you the whole video. I'll just show you. So, in double-headed pterygia, what you can do is you can take a donor conjunctiva and then split it into 2 halves and put it. But sometimes one, especially the nasal pterygium, can be a lot larger than the temporal one. So what, I'm sorry, the previous video didn't play. So what one could do is you can actually, instead of when you take a large rectangular graft, don't divide it completely, leave a little hinge at one corner, and then you make a long strip. And that strip can then be divided unequally. You can put one larger strip, part of the strip on the extensive pterygium and a smaller one at the smaller pterygium. And then the rest of the area can be covered either by amniotic membrane or by mobilizing the peripheral conjunctiva. If you do have early recurrence, it's not a big deal. You can deal with it by putting an intralesional triamcinolone, and it really helps actually, and stepping up steroids. But if you do have recurrence, then repeat pterygium, and in such cases, using an antimitotic agent like mitomycin C may be reasonable. Triamcinolone really makes your life a lot easier, and if you pick it up early, putting in that little triamcinolone will really arrest the pterygium in many cases. So to conclude, our threshold for surgery has lowered. We are doing a lot more cosmetic procedures. Conjunctival autograft is the gold standard. Fibrin glue is a quick fix alternative, which makes it faster and gives good outcomes. The principle, just remember, follow the principles, and almost always you will get a good outcome. Thank you. Even if it's a recurrent pterygium or a very extensive double-headed pterygium, I almost have never used mitomycin C in any of my pterygium surgeries with wonderful outcomes. Thank you.
Thank you, Dr. Rishi. That was an excellent talk and right on time. Dr. Rajesh, can we go on to your presentation now? I think we'll all finish our presentations and then we can have a discussion on all the topics again.
Yeah, if you stop sharing, then I can.
Yeah.
Yes.
I've stopped sharing.
Yeah. Yeah, my talk will be on surgical management of corneal ectasia. No financial interest. Corneal ectasia in the clinical practice, commonly you will see keratoconus, you see post-refractive surgery, progressive corneal ectasia. Rarely do you come across pellucid marginal corneal degeneration with inferior thinning, and sometimes you will see extensive thinning of the cornea, what you see in keratoglobus. Although the initial management is conservative using all various kind of special contact lenses, but at times it reaches a point when you have to consider a corneal surgery. Traditionally, we have been doing penetrating keratoplasty, but the other options are deep anterior lamellar keratoplasty, stromal augmentation procedure or Bowman layer transplantation, and sometimes certain cosmetic customized corneal surgery. I'll be talking the three topics. Deep anterior lamellar keratoplasty refers to a surgical technique where over 90% of the corneal stroma is replaced with healthy donor tissue and the host endothelium is retained. So thereby the advantage is you don't have risk of endothelial rejection and you don't need to use prolonged topical steroid therapy. And the surgery is also performed in a closed chamber, so the risk of intraoperative complications is also low. There are two basic surgical techniques. One which involves injection of air, viscoelastic or fluid into the stroma, resulting in exposure of the pre-descemet layer. And the second one is a manual layer-by-layer dissection, where you try to go as close to the descemet membrane as possible. And in current time, this can be aided by the intraoperative OCT. In the pre-op evaluation, we need to have some idea about the regional pachymetry. You do perform a corneal OCT, which can help identify if there is any pathology that involves the descemet membrane, in which case you may avoid any kind of stromal injection. The basic steps of DALK surgery is a 85 to 90% depth refination, followed by anterior debulking, placement of the air injection cannula. You inject air to create a plane of separation between the stroma and the pre-descemet layer, referred to as the big bubble. Then you open up the big bubble, excise the residual stroma, and then place your donor graft and secure with sutures. A sequential approach to air injection is much safer and allows a much larger size type 1 bubble, which can go up to the edge of your trephination margin. So after initiating the type 1 bubble, you do a paracentesis to release aqueous, lower the intraocular pressure, so the counter pressure is reduced. And then expansion of the type 1 bubble is much easier without increasing the intra-bubble pressure. Sometimes you can inject cohesive viscoelastic into the stroma instead of air. Now in this case, you can see that we have kept an air bubble in the anterior chamber, lowered the intraocular pressure. Now I am injecting the cohesive viscoelastic and it creates a visco bubble, creating the same plane of separation. And you can see that the air bubble moves to the periphery. Post-operatively, these eyes do very well with nice clear graft. The best part is the endothelial cell counts are maintained and the attrition rate is much lower than what you see in a traditional penetrating keratoplasty. This is a post-femtosecond laser-assisted DALK. Here, the advantage is that you can have shaped corneal incision, so peripheral graft-host junction is stronger, the surface area is more. So this is a mushroom-shaped graft that we perform. But you can also do a zigzag or other configuration. The refractive outcome seems to be a little better because of the better fit of the donor and the host. That's the post-operative topography of the femtodalk. You can see looks pretty regular. In cases where there are scars that involve the decimets, you can still perform if the DALC if the scar is not involving the visual axis. So here, basically, we do the trephination followed by debulking, an initial debulking which is done, wherein about 50 to 60% of the tissue is removed. And then we make a deep peripheral pocket going close to the decimus membrane. And that's a stromal pocket forceps that I designed, which is available from stores, no financial interest. You can use a pair of scissors also to make this groove, but you have to be careful when you use scissors not to perforate posteriorly. And then you're doing something like the peeling technique described by Enrique Malbran. So your left hand has a tooth forceps that's trying to lift up the residual stroma. And as the fibers kind of separate, you are using the lamellar dissector to break the adhesions. So a single plane is maintained and you can go pretty close to the decimus membrane. So that's a pre and post photograph. You can see the central scar, and in the post-op, you can see a nice uniform thickness and a very minimal residual bed, which measured only about 30 to 35 microns. If you have intraoperative OCT, it gives you an advantage that in real time, you can see what's the residual bed like, and you can decide whether any further dissection needs to be performed. So in this flowchart, basically for big bubble DALC, based on the clinical evaluation, depending on whether the scars are involving the decimus membrane, what is the thickness of the cornea, whether the steep K exceeds 70 diopters, you can decide whether you're going to do an air injection or a manual DALC. And even when you inject the air, depending on what type of bubble you get, if you get a type 2 bubble, it's advisable not to open it up, but to proceed with a near decimus manual dissection. The other technique that we have been doing is the stromal augmentation, where using so these are basically in moderate keratoconus patients who are contact lens intolerant and are looking at surgical options. So here, using the femtosecond laser, we create a stromal pocket at a depth of about 200 microns from the surface, measuring about 9 millimeter in diameter. So the corneal lenticule that's prepared measures somewhere between 200 microns to 250 microns. You can even cross-link it if you want, or you can even insert it before and plan for a cross-linking at a later stage combined with a topography-guided surface ablation. So implanting the lenticule is pretty simple, can be done under topical anesthesia. So that's the early post-op appearance that you see on the left. And this is the case, 19-year-old female. You can see there is moderate keratoconus. There is a lot of high order aberration, significant amount of coma. She was not able to wear a contact lens. And this is after 5 years after doing the stromal augmentation. You can see there is a significant reduction in the coma. The cone looks much more central, and her visual acuity improved to 20/20 with 4.5 with -4 cylinder. So at this stage, even if you want, you can go ahead and do a toric ICL and give her good unaided vision. So that's the difference map between the pre and post. And you can see that there is significant amount of central flattening that you see in this case. And that's at 5 years. You cannot really make out the stromal lenticule that you have put in. It has, settled down very well in the corneal tissue. This is another patient I did recently. So here you can see the pre and post lenticule insertion. So the difference here is that what we did was we modified the lenticule by doing a central ablation in the lenticule. So making the central part of the lenticule slightly thinner than the periphery. So that's the difference map between pre and post. And you can see there is a normalization of the cornea. The cone the steep part has moved much more central. There is good amount of central flattening. See the significant difference in the high order aberration and the coma between pre and post. And the patient's visual acuity did improve from a preoperative 20/80 to he was seeing 20/30 with glasses alone. That's again the change in the thickness. You can see pre and post. His post-operative thickness has improved to 582 microns. And now we can think about doing a topography-guided ablation if required. At times, you are presented with these kind of extreme ectasia, wherein you have, like keratoglobus. So this patient, one eye was lost from a prior attempt at penetrating keratoplasty. So in these kind of scenarios, we have to do a customized procedure. So we planned on doing a DALC because the cornea was uniformly thin all across. Only Donald can do a nice DALC, staying within the cornea in these kind of cases. So I had to make my, size of the graft larger because I wanted to secure it to the sclera. So we opened up the conjunctiva in a way that the limbal stems are included in the conjunctiva. The pigmented palisades are kept in the conjunctiva, so you don't get a limbal stem cell deficiency. Then we carefully went ahead and we started doing a stromal dissection. So we managed to do that. That's the donor graft that's been prepared. We did encounter 1 or 2 microperforation. The graft was secured into place. We had done an inferior PI and then we did a complete air fill. So that's the post-op appearance. You can see there is a significant change in the corneal curvature. So his visual acuity improved to 20/30. Cell count was at 1,285. That's from the increased surface area within the cornea. He's now completed 5 years follow-up and still maintaining good vision. That's on the shine plug. You can see the pre and post-op change in the curvature. A similar case where there was previous eye drops as well. So here, when we did the procedure in the center, we did a full thickness opening and we put in a 6 millimeter diameter a DSEC lenticule, and the large diameter corneal graft was placed. And that's the post-op appearance, and that's at follow-up. You can see even his vision improved to 20/20, and there's a nice clear corneal graft. This is something that I operated recently. This is a lady who had had an RK done when she was 8 years old, and then she had a cataract surgery done, and now she is 52. She's not able to see practically using any kind of lenses, severe corneal ectasia. And then we went ahead, we prepared the donor using a microkeratome. We made a 300 micron cut anterior lenticule measuring 9.5 millimeters. And the remaining tissue, 6.5 millimeter, we punched out a endothelial lenticule. In the host eye, we created a diamond knife to make a 9.5 millimeter groove all around, did a lamellar dissection to the best extent possible, and then we created a central opening into which we put the DSEC graft, and on top of it, we put the 300 micron lenticule, secured it in place, and you can see by day 2 post-op, the cornea is looking great and she's feeling an improvement in her vision. So basically, in conclusion, surgical options for corneal ectasia varies with the disease severity and the extent of corneal involvement. DALC should be considered as a procedure of choice for corneal diseases with healthy endothelium, so you should not go ahead automatically doing a penetrating keratoplasty. The techniques are evolving to ensure greater success of the big bubble DALC, especially with the proper case selection. You can avoid complication and reduce the transition period from doing a penetrating keratoplasty to learning DALC. The femtosecond laser technology and the intraop OCT definitely will help improve the outcomes in future. Thank you. Thank you for a patient hearing. So our next speaker is Dr. Nitesh Narayan. He is also a bright young corneal surgeon, and he'll be talking to us on the various applications of collagen cross-linking in clinical practice. Dr. Nitesh, please.
Yeah. Thank you, Dr. Rakesh. Thank you for the invitation, Dr. Rajesh Vogla and Telangana Ophthalmic Society. I'll be talking on collagen cross-linking and its clinical applications. We all know collagen cross-linking has established its role in management of corneal ectasia cases. So I'll not be going into. Am I audible?
Yes.
Yeah. So I'll not be going into its indications in its management protocols. So what I've done here is I've gone into what are the different protocols available for doing cross-linking. What are the variations in cross-linking available for doing keratoconus, and what are the newer techniques available for doing cross-linking. So when you come to the different protocols available, you have different riboflavin solutions available. The commonest solutions which we have been using is 0.1% riboflavin with 20% dextran. And then we have with HPMC with benzoyl sodium with EDTA, especially when we have epithelium on, when you want to do epithelium on procedures. And when we have thin corneas, we can use it with 0.9% sodium chloride. And then we can also use it with methyl cellulose as well. So coming to the variations in cross-linking, we have had many variations. The very popular variations were the accelerated cross-linking. Okay, the basic hypothesis why the accelerated cross-linking has become very popular is on the principle of Bunsen law of reciprocity. Basically, the certain biological effect is directly proportional to the total energy dose irrespective of the administered regime. So basically what they hypothesized is when the total exposure is of the radiation is say as around 5.4 joules, the effective radiation is effective. So based on that, various protocols has been tried. Some of the initial studies were done by Spohl et al. And there they had done on around 100 porcine eyes, and where they had divided around 100 porcine eyes into 10 different groups. And they were treated in on different protocols varying from 3 milliwatts to 45 milliwatts, and on the duration from 3 minutes to 45 minutes, 30 minutes. And what they realized that as long as the intensity or the 5.4 joules is same, the effect is remain the same. So on that protocol, the accelerated cross-linking has become very popular, and this has been tried on human eyes as well. This has been tried in young patients as well. Rohit Shetty and et al. Had published this report they had done their study in 38 young patients. They had done in patients less than 14 years of age. And then they had basically done with a protocol of 9 milliwatts for 10 minutes, and they had followed it up for 2 years. And they had shown that all the patients had a good visual improvement in their best visual acuity and a good visual outcome as well. And when you see the different comparison between the different protocols, which were also compared with the standard cross-linking as well. This was the study done by Dr. Donald group, where they had compared the conventional group with the accelerated protocol. They had around 76 patients, which were divided in the two groups. One group were in the standard protocol of 30 minutes for 30 minutes, and one group was for the 30 milliwatts for 4 minutes. And there was a good outcome in both the groups. And there was another study by Rohit Shetty et al., where they had around 138 eyes, which were divided in 4 groups. Where one group were of the standard group protocol of 30 minutes duration, and the other 3 groups were of 9 milliwatts for 10 minutes, 18 milliwatts for 5 minutes, and 30 milliwatts for 3 minutes. And what they had concluded was the results were comparable of the accelerated protocol of 9 milliwatts, 18 milliwatts, were comparable with the standard cross-linking. So there was also a very interesting meta-analysis where they had done of almost 11 trials were included in the study, and they had done a meta-analysis of all the trials which were done, which were included up to October 17. And what they had done, they had done a very interesting study, and they had compared around seven primary and secondary outcome measures. And they had what they had done was they had compared the corrected distance visual acuity between the standard and accelerated cross-linking, and they found that there was no statistical significant difference between the standard and accelerated cross-linking groups. And when you see the mean keratometric value, there was no statistical significance difference as well between the standard and accelerated cross-linking. When you see the maximum keratometric value, there was some difference when you compare the standard versus the accelerated cross-linking. When you see the other parameters, the other secondary measures like the corrected distance visual acuity and the mean spherical visual acuity, there was no statistical significant difference between the standard and the accelerated cross-linking. When you see the central corneal thickness, because accelerated cross-linking, you are applying cross-linking for a smaller duration of time, there was definitely reduced thickness in the initial period. But overall, for more than 12 months of follow-up, there was no significant difference between the central corneal thickness as well. And when you compare the endothelial cell density as well, there was no statistical significance difference between standard and accelerated cross-linking. So I think standard cross-linking has become a standard of care in cross-linking of cornea in ectatic cases. And when you come to cross-linking borderline or thinner corneas, this was a challenge always, but now we have hypoosmolar solutions for cases which are less than 400 microns. We can use a riboflavin solution with 0.9% sodium chloride. This was popularized by Reisik Spol et al., which was published way back in 2013. We also have had transepithelial cross-linking, where you need not remove epithelium. There were reports that the patient does have a very good faster recovery and less epithelium haze post-operatively. But when you see the comparison between both the groups, there were some differences, like it could be the epithelium on procedures. The patient does have a faster recovery and less epithelium haze. It can be used with thickness which are less than 400 microns. But studies have shown that the incidence of progression is much higher in patients who have undergone cross-linking with C3R, which are more than with cross-linking which is done with epithelium on procedures. Then you also have which we can also use contact lens induced cross-linking in thinner corneas. This was publicized by Jacob et al., the Agarwal group, where we have thickness, stromal thickness, which is less than 350 microns. What they do is they use the riboflavin soaked contact lenses with soft contact lenses. The important thing is you need to use a contact lenses which doesn't stop ultraviolet radiation from which doesn't stop the ultraviolet radiation from cross-linking the cornea. And so basically you can use the contact lenses soaked with riboflavin solution, which can act as a bandage for cross-linking the cornea. You can also have intralace assisted cross-linking in early cases of keratoconus. In this, you have an corneal pocket which is created at 100 microns depth, and riboflavin is applied every 2 minutes, and then you apply 7 milliwatt radiation for 15 minutes. So it basically crosslinks 60 microns anterior and 200 microns posterior of the cornea. Then you, for post-LASIK ectasia, we have realized that whenever you, in these cases, especially lifting of a flap can be a problem, and whenever you crossing these corneas, the edge of the flap can, you could have folds post-operatively. So you have something called Sanchez-Leon technique, where you don't lift the flap, you just you make a you'll use a spatula to make a pocket similar to a smile procedure, and then you riboflavin is then inserted into it. Then you apply, then you cross-link the corneas. Then you have newer techniques in cross-link. You could cross-linking had been used for treating corneal ulcers as well. This was a clear trial where they had about 266 patients by the Arvind group, where they had divided into 4 groups, where cross-linking with, this was a filamentous keratitis, which were divided into 4 groups, and cross-linking with amphotericin and cross-linking with natamycin, and amphotericin and natamycin alone. And what they had concluded that at 24-hour repeat culture, there was no benefit in the cross-linking group. And even at in the cross-linking group as well, there was decreased visual acuity at 3-month follow-up. And so they had concluded that there was no improved efficacy of cross-linking in managing keratitis patients. Then cross-linking with topo-guided PRK has become very popular nowadays. The aim is to regularize the corneal surface and make the patient more tolerant to contact lenses. Basically, the treatment profile is to make the cornea more regular. The goal is to make the patient more tolerant to contact lenses, and make the cornea more rigid as well with cross-linking. And then with the cornea, the Kinepolis group have come out with an enhanced Athens protocol as well. What they are doing nowadays is that after the initial 50 micron ablation of the epithelium, they do a topo-guided partial 30 micron PRK, and then they are doing a partial or a customized variable pattern.
Time. I would request you to please sum up in next 30 seconds.
Yeah. So what they are doing is they are doing a topo-guided treatment of the C3R as well. So in conclusion, outcomes of the epithelium off procedure are better versus epithelium on procedures. Accelerated cross-linking has established itself is as standard care of cross-linking. Cross-linking doesn't work for microbial keratitis, and there is hope of vision improvement in moderate cases of keratoconus with enhanced Athens protocol in topo-guided PRK cross-linking. Thank you.
Thank you, Dr. Nitesh. I think we still have 5 minutes. If we have a question or two, I think we can go ahead. Rajesh?
I think one of the points what Nitesh mentioned, that cross-linking is not beneficial in infective keratitis, may not be correct. What I would like to remodify that statement in a way that the current protocols that you are using for cross-linking, that may not be effective for treating infections. But modifying the dye, like a rose Bengal dye, and using different exposure and energy levels, people have shown, good outcomes, especially more so with bacterial keratitis. We still are investigating its role in fungal infections, but this is again something that time will tell, and we don't yet have a clear answer. But yes, if you use a standard protocols for cross-linking, if you use for infections, they have not shown any dramatic results.
Yeah, you basically have to use a much higher fluence,
Yes.
almost 3 times.
So if you listen to the presentations from Farhad Hafezi, it seems that he's kind of accumulating results worldwide as well. So people who are doing various studies, there are some studies going on in Israel as well, and they have found it to be useful. But see, it's very difficult to design a study where you give cross-linking alone and don't give any
Antibiotics.
additional antimicrobial therapy. So traditionally, if you do an RCT where you give antimicrobial and the other group you only do cross-linking, then maybe head-to-head you can compare. But if you are doing cross-linking and continuing with the antimicrobial, you don't know whether it's the cross-linking that has helped or whether the antimicrobial therapy had also some role to play in the resolution.
The only thing which doesn't make sense is, sometimes we do see post-cross-linking infections.
Right.
They're related to the contact lens, but the fact is you've done a cross-linking and then you end up with a keratitis.
Correct.
I think it was a very nice session. Thank Dr. Rajesh for organizing such a good compilation of talks. I think started with a bang with Donald Tan today morning. I thank Rishi, Nitesh, and Rajesh and all of us here. And I hope the audience have some good points to take home today morning, and wish all the best for the meeting as it goes ahead during the day today. Thank you.
I think all of us
Thank
had some good points to take home, not just the audience. Lovely talks, everybody.
Thank you, everyone. Enjoy your Sunday.
Very
Thank you.
insightful and comprehensive talks by all our speakers and very well moderated by Dr. Nitesh. Thank you so much, Dr. Rajesh and Dr. Nikhil, for chairing this session. Before closing off with this session, I would request everybody to please turn on their cameras and unmute their lines so that we can have a huge round of applause for all the speakers, presenters, and have a virtual photograph click. So let's hear it for all of us. Great. All right. Thank you. Thanks, everyone. We'll conclude this session and we'll start with the next session at 10 a.m. sharp. Thank you.